Hello there, this is Sheila Davies and thank you for joining me this lunchtime on this webinar around improving health services for disabled children. I've been working at Contact Family now for over 10 years and I work very closely with the British Academy of Childhood Disabilities, which brings me in contact with neurodisability paediatricians, but I also work very closely with parents and parent carer forums. I realised that looking at the audience of people who have registered for this webinar, we've got quite a mix, but it includes a lot of commissioners and clinical commissioning groups who might be quite new to disability services. So for the first 20 minutes of the session, I'm going to really just be looking at the existing health services that are supporting disabled children by way of an introduction, but also highlight some of the problems that are happening across the country at the moment with the current system. I will then be moving on to talk about how in some areas across England these services have been improved by practitioners and commissioners working very closely with parent carer forums and actually looking at ways to make services more efficient really by reconfiguring them and changing the way they work, rather than investing large amounts of money into them. And then for the last third of the seminar, I'll be looking at the SEND reforms, which are being introduced in 2 weeks' time on the 1st of September 2014, because I realise a lot of the audience have probably been asked to get involved with implementing these and coordinating health input. I do honestly believe that the SEND reforms provide a real opportunity to improve the way health services are delivered to disabled children, but I suspect a few of you who have actually been asked at very short notice to suddenly get involved with this, it perhaps doesn't feel like an opportunity at the moment. But it is an opportunity, but I do recognise that bringing about change like that and bringing about improvements will take time. So to begin with, really an introduction to how do things work at the moment, and I thought it might help if I illustrated this by showing 3 very typical pathways for children and young people into health services around disabled children. Because when we say disabled children, it can mean all sorts of different things, lots of different types of disabilities, but also different levels of severity. So what I would like to do first is start with child A, who is very likely to be identified at birth or soon after birth. It could have been there was problems at the birth and the child's was starved of oxygen. And these children might have a diagnosis, something like cerebral palsy or Down syndrome, and very much depending on the nature of the disability, they could need support around feeding and eating. They might need help to support them to learn to speak, or if not to speak, to communicate. They could need support around their mobility and fine motor skills, and they're very likely to need help to support their learning and also to help them learn to take care of themselves in everyday life. Some, the more complex, are likely to become eligible for continuing care. And so the first question is to think about, well, who in health is involved in supporting these children? And the answer is an awful lot of different health services and other agencies involved in supporting these children. And this diagram really illustrates how complex it can be. But what I would like you to do to begin with is just hone in on that square at the very centre of this diagram where it says Child Development Team. And within that you can see it says child and family, because usually these children are supported by this multidisciplinary team, and they provide what's known as a team around the child way of support. So you will normally have a paediatrician, specialist nurse, physiotherapist, speech and language therapist and occupational therapist, and they very much work together as a team and work to support the child and the family. And the paediatrician's role is to refer and pull in those other services as and when they needed and coordinate that process. You'll see, looking at the diagram, that around that central box there's highlighted boxes around it. For instance, at the top it will say posture, movement, balance and coordination. So this is the type of issue that these children might need support on. It could be that the child development team can support that child without needing to access any other service, using it with a physiotherapist and the occupational therapist, but it could mean that they need to refer to somebody like podiatry and orthotics service or the wheelchair service for some of the children. So that is how the system works at the moment. And again, if you look at the other green boxes surrounding the child development team, these are just a list of the sort of common issues that, regardless of the diagnosis or the name of the condition, these are some of the aspects that the child and the family might need supporting on. Things like learning to communicate with the rest of the world, help with feeding, eating, I've mentioned. Other things like toilet training could be much more complex, and these children are very likely to have issues around poor sleep, and could well have challenging behaviour, but not necessarily. I think when you look at this diagram, you can also appreciate, how complex it is. You'll see at the very top of the diagram it says key working, because some families have key workers who help coordinate the service for the family. And looking at the complexity of the diagram, you can see why someone coordinating things for them is really important. You will also notice that the boxes in orange, with a background of orange, education and social care, they are also likely to be involved with these families. And this really, I think, illustrates how important it is that health and education and social care all work together and coordinate that input. So a bit more about key workers and key working approach. These act as a single point for the family, and they'll coordinate the family supports. Key working is recommended in the recently published NICE Autism Guidelines, and also the SEN Code of Practice. In some areas they might be called a lead professional or a care coordinator. It could be a professional involved who sees the child a lot who's taking on this role, or it could be that there's a family support worker at the children's centre or provided by the voluntary sector who would provide this role. For those who'd like more information on key working, you can look on the Council for Disabled Children website, and they have a lot of information more about key working and developing a key worker service. But for the moment, I'd just like to sort of go back and really expand on how the child development team works, and how important it is that they work as a multidisciplinary team. That team, I've already mentioned the therapists who would be involved with support them. They might also need input from psychologists, psychiatrists. And what that team does is it considers the different areas of development that the child needs support on, and then decides, well, what's the priority and what interventions are we going to use to actually help the child develop skills in that way. Very often it's the therapists who are actually assessing and saying this is what will help the child develop the skills, but these interventions are provided within the school and by the parents and within early years settings, because it is the people who are with the child day after day and seeing them frequently. It's most effective if they are the ones who are delivering the interventions. And again, the therapist's role would be to come in and to review how is that working, and then once the child reaches their goal or target, then come up with new interventions to support their development to the next stage. This process is really most effective in the first few years while the child's brain still has some plasticity and is still developing. For those who are really new to Disabled Children's Services, Contact Family has a guide called GP Practice Guide supporting disabled children and young people that explains in a bit more detail the different services involved in their roles. And if you look in there, you would also have the opportunity of having another look at that diagram that I showed in the previous slide, showing the different services, who might be involved. For the moment now, I'd just like to sort of give you an example of how the child development team, using this team around the child approach, might, how it works as a sort of practical example. Because later on, when we're talking about the SEND reforms and the EHC plans, I think they mimic, in a way, this sort of approach. So for the moment, if you imagine the situation where this family is attending their regular review meeting, they're going to a meeting where they've got the different therapists involved supporting their child all in the room together. And the meeting would begin with the family being asked, well, how are things? What's happening? What's difficult for you? What are the things you want to work on? And based on that, the team then agreed to work together to help support the child around what is that agreed outcome, what it is we want to look at and work on first. So in this example, the family are reporting that they're finding meal times extremely difficult because their child, who is still spoon-fed, is having many temper tantrums, is refusing food, and the family think that the child is just frustrated because she cannot feed herself and doesn't like being spoon-fed. So the team would say, well, let's prioritise that. Let's try and support the child to learn the skills to feed themselves over the next few months. And the different health professionals involved would think, well, what can I do to support the child to meet that outcome? So the physiotherapist might devise exercise to help the child improve their arm-hand coordination, so the child can start getting those physical skills that they will need to help them pick up food, to feed themselves, and to use a spoon or a fork. The speech and language therapist might think about providing advice about what sort of food consistencies the child is safe to swallow. They might also look at, well, what exercises could we actually give the child to try and help develop their muscles so that they can swallow food more safely. And the occupational therapist would look at, well, can we help with seating and equipment so that the child is well supported when feeding, and is there equipment that they might find it's easier so that the child can use to feed themselves. So it is this approach where we're looking at what the child, the young person and the family wants, and looking very much at outcomes, and everybody is working together to support the child to meet those outcomes. So moving on, because I said we'd have 3 children, and this is child B, is very commonly children enter the pathway around the age of 2 to 3, when it's seen that the signs of developmental delay. This might be that the child is late in sitting up or walking. It could be the child is late in developing speech and communication. Various people might pick this up. It could be the health visitor. It could be the early years settings. It could be the parent has gone to the GP and said they're a little worried that the child's not as fed as other their brothers and sisters have been. And it could be, it could be the early years settings. So what happens then is the child would normally be referred for a general assessment to the child development team, who would actually look and assess this. They might require input from psychiatrists and psychologists, and the assessment might eventually lead to a diagnosis, but I have put the word eventually in italics because many children never actually get a name for their medical condition. They might be diagnosed as having a learning disability, but there's no medical condition diagnosed. It doesn't mean they haven't got additional needs. It just means that the health professionals have not actually come up with the name of the medical condition that's caused them to have those additional needs. I would also say that there is a wide variation across England in how long it takes for children from being referred to being assessed. The NICE guidelines on autism say it should be 18 weeks from referral as possible autism to a completed assessment, but I am aware that in some places across England this process can take 2 years or even longer. I would say that clinical pathways are important. If assessments are delayed, when getting support for the child is delayed, then the consequences of that could well be much poorer outcomes for the young person in learning to support themselves and live independently. And I think clinical pathways are important, and I think if there are bottlenecks in your area, it is probably worth looking at other areas that don't have those bottlenecks and saying, well, what do they do? Is there a way we can improve our clinical pathway? So these children who are picked up at age 2 to 3 might, similar to child A, they could have difficulty with speech and communication, including interacting with others. They could have problems with coordination, fine motor skills. Learning new skills could be more difficult for them in terms of learning skills to look after themselves, to cross the road safely, learning to become continents. Quite often these children have a thing what's called sensory overload, which is really where they're very oversensitive to sound, or to textures, or to bright colours. And this can make things, especially the school environment, extremely difficult. Quite often these children could also be fatty eaters, or they might refuse certain textures of food. Poor sleepers. Children with neurodisability are much more likely to have problems around sleep. And sometimes this can be in actually getting to sleep, but some children just don't sleep for very long. And I'm continually meeting families who manage on 4 hours sleep a night. For those of you who are parents, you can probably remember when your babies were very young, what it was like going night after night with interrupted sleep. But imagine what it's like if 10 years on you're still only having 4 hours sleep. There are interventions that can actually sometimes help, and help the family to develop better sleep habits for the child. But very often families do not hear about these. These children are also high risk of developing behavioural challenges and high risk of developing mental health issues. And again, without early support on these problems, they can become very entrenched and much more difficult to reverse. So again, thinking, well, who in health might be involved in supporting these children? And the answer is actually possibly no. Because what happens in most areas is once the child has been assessed by the child development team and diagnosed, a letter is sent to education and social care and they're discharged from their care. This is because the view is, well, you know, we've diagnosed the child, but it's not a treatable medical condition. And so the assumption is usually that somebody else is picking up and providing support for these children. But very often they're not. What then happens is the school is required to use their budget to provide support for the child with their additional or special educational needs, and this used to be called School Action and School Action Plus, but is now being replaced by what is called SEN support in the schools. And if the child's needs are so complex and that they cannot be met by the school, then it used to lead to families could ask for a statutory assessment leading to an SEN statement, and again that has been phased out. We'll talk about that later. But you can see what happens here is that the schools are concentrating on the SEN support needs, but nobody's picking up the support for the families to give them strategies to manage behaviour, sleep, toilet training, feeding, eating. And the NICE guidelines on managing autism, which were published last year, do say that children should be referred to an autism team for support on these issues. However, when I travel across England, I don't normally find that there is an autism team in place. So this is an area, this is a gap that is happening in many places across England, and I really wanted to draw this to your attention. Finally, the third child I wanted to talk to is fairly typically aged 5+, but again, those problems identified often by the school. It could be that developmental delay wasn't picked up till the child attended school. Often it could be that there's problems with communication, social interaction, maybe challenging behaviour, problems with learning. Child development teams in England often only see children aged 0 to 5. That is not true in all areas. In some areas the child development team continues seeing children aged 0 to 19. But where there's no child development team available anymore, these children therefore go in with a different referral and a different pathway, and they're likely to be referred to a community paediatrician or to the Child Adolescent Mental Health Service for assessment. And this, and again in italics, says this might lead to a diagnosis of autism spectrum disorder, a learning disability, ADHD, or mental health issues. But what is happening at the moment is our helpline is frequently hearing from parents about the Child Adolescent Mental Health Service just refusing to carry out assessments on children being referred by schools and paediatricians because the children are not deemed bad enough to be eligible to be seen. And what is happening therefore is these children are being left in limbo because there's no assessment and no support is being put in place for those children as well. So now I just picked up, we've had a couple of questions have come in, so I will just try and answer those quickly before moving on to the next section. Julie Standing has said, well, how do other professionals know who the key worker is? Well, that's a good question. I think the first thing is to say you need to ask the family if anybody is actually coordinating and helping them coordinate the support. This person, as I said earlier, might be not called a key worker, they might be called the family support worker, or it could be a professional who's taken on that role. But do be aware that many families do not have a key worker, don't assume they'll have one. And Deborah Hives has said, well, what would be in place if your area does not have a child development team? Well, all areas in England do have a child development team, but often they are called something different. They might be called the Child Development Unit, the Child Development Centre, Disabled Children's Centre. Some of them are even called Children's Centre for Disabled Children. If you can't find one in your area, I would suggest you contact your clinical commissioning group because they're responsible for commissioning them, so they should be able to provide you with details. I would also assume that the details would also be in the local offer that will be published, if it hasn't been published already, which certainly should be there from the 1st of September. So now I'd like to move on to the second section where we really talk about how services have been improved, because I've given you, I've hopefully given you a feel for how things happen and also how things can go wrong. And what I wanted to do now was sort of focus on how in a few areas commissioners, practitioners have worked with parents and parent care forums to actually reconfigure services to make them work better and so that they're working more efficiently and that children are essentially getting the support that they need. So why involve parents and why involve parent forums? And I hope well, I think the slide speaks for itself. You only actually know if the service you're providing is working if you actually ask the person who is using it how it is working. And over the last few years, there's been a huge increase in parent care forums developing across England, and this is parents who have come together and want to work very much with services to improve how they work, because those parents, when they meet each other, they discover that actually some of their problems that they see as individual problems, many other parents are facing. So what is it like for parents of a disabled child trying to access services? And I think this next slide is what I call parents' version of the slide I showed you earlier, which showed how all the different services net together with the paediatrician coordinating it. The parent carer's view at all is often there's all these different individuals they're trying to get involved or are involved in supporting their child, and it's often they're the ones who are having to try and coordinate everything. And it's not always, it's not just about the health needs for the child. They're trying to get education support for the child. They might be trying to get transport so that they can get around, equipment, adaptations to their home, and also finance. Many of these families, the parents cannot work because they're caring for the disabled child, so they are reliant on benefits. And we do know from Contact Family research that over 50% of the families contacting us are actually living below the poverty line. So I think you can see there what happens with parents is they find the people who help them navigate through the system are other parents, and it's other parents who often are the best sources of information for them. And what's happened is when they come together and they see shortfalls, it leaves them with a desire to want to make it work better. And that is why over the last 6 years, parent care reforms have been supported by Contact Family and with financial support from the Department of Education to develop across England. And parent care reforms, there's one in each local authority area, or in most local authority areas there's one now. They are pan-disability, so it brings together parents of children with different disabilities, different ages. And their whole purpose, if you like, is to work with local authorities and health services to help make sure that the services that are being planned and delivered actually meet the needs of disabled children and families. You can read more about parent care reforms on our website, and what has also happened is the parent care reforms across England have developed into a national network, so they come together and talk to each other both at a regional and a national level, sharing experience and really communicating with each other what is working and what is not working well. And at a national level, representatives of the National Network of Parent Care Reforms work closely with the Department of Education, Department of Health, other national bodies to really try and influence how things work locally. And the National Network of Parent Care Reforms have been very closely involved in the in working with the DFE around the SEND reforms, and parent care reforms have been very involved in the areas where there have been pathfinders developing and went ahead with the SEND reforms. And so moving on, one of the things that Contact Family published in May this year was this guide called Sharing Good Practice in Health Settings. And what the guide gives is, I've mentioned some of the problems that are happening across England. This has got 10 examples from different settings around how at a local level people have solved and addressed some of the issues and the problems that I've mentioned earlier on in the beginning, the first section of this webinar. So they're just examples of how parents working with local authorities and health services especially have actually improved the way that services are being provided for disabled children. You can download an electronic version from our website, or you can email us and request printed copies. Having a printed copy can be quite useful if you want to show it to someone else and share it with someone else. So what I'm going to do now is I'm not going to go through all 3 examples. I've picked 3 that I would particularly like to share with you just to give you a flavour of this work and how it works. And the ones I thought really most pertinent to the SEND reform agenda at the moment. So the first example came from Perth, and it's around parents influencing the way the Child Adolescent Mental Health Service works in that area. And the background to this were parents were not happy with the CAM service for children with learning disabilities who also had mental health issues. And the Commissioner was very interested to know about more. So she approached the parent forum and asked them if they could help run a workshop and consult with parents on this. They thought very carefully about having a structure to this workshop and about what questions they were going to ask the parents. And 4 questions included what causes the child to be stressed, what impact that has on the child's life as well as the family's life, their experience of CAMS, but also, well, what did the families think would help. What was interesting, and that there's a lengthy report that came out of this workshop, but when they asked the question, what causes the children to be stressed, that there were quite a few common topics. But one was very much the child and young person wanting the opportunity to have fun with friends and not having opportunities to sort of have social time with friends. But the big one was school. And the parents were saying very often the staff in the school do not understand how to support our child's disabilities and support their behaviour and emotional needs, and the way they interact with the children are causing the children to become stressed. So this led to a new service specification being written, first at a Tier 2 level, where the Commissioner decided, rather than involve CAMS, she brought in a voluntary sector organisation that had a lot of experience of working with children and young people with learning disabilities on helping them to support and manage their emotional and behavioural needs, and actually getting them to go and work in the school with the school staff to help the school staff learn and understand what they needed to do to help manage and support their children. And they also recognised that parents needed similar information and help. So within the school, there's parent groups, and the same organisation goes in and talks to the parent groups in there to help the parents develop the skills they need in managing their child's emotional and behavioural needs. It also, they developed, when they recommissioned the Tier 3 service specification, they also included a learning disability nurse to work alongside the psychiatrists and psychologists there, and also a couple of family support workers whose role was to sort of work and link in with other services like social services and short break services, so that the support they could provide to the family was a much more holistic one and could help address this issue around giving children and young people opportunities to have time, fun time and social time with other children, which is so important to support their mental health needs. So the next example, the previous example was how we can consult with it, use a parent forum to consult with parents. This example is actually more how working with parents, we can actually get them to participate at every step of the process. And this came from Hampshire, where again the background was the parent forum picked up their problems with therapy services in Hampshire. And at the time, the therapy services was not being, it had not been commissioned as a multidisciplinary service. So the speech and language therapists were working in one centre, the physiotherapists in another centre, and the occupational therapists in a different centre. This meant that the families were having to go to different centres to see the different therapists, and there was very poor coordination. There was also quite a postcode lottery, with some families having extremely long waits, such as 2 years to see an occupational therapist, where other families were actually getting quite a good service. There was also problems because children were sometimes being assessed, but then when it came to being reviewed, these reviews were not happening. And I think I explained earlier the importance of the therapist's role in providing interventions for the school and the parents, but then once the child's met that outcome, we need to assess it and say, well, where are we going to move to next? What's the next step? What interventions do we need to support that child to get to the next stage? So what happened is the Parent Care Forum ran a consultation. They have about 400 or 500 members in Hampshire for forum, so they ran a consultation to get the quantitative and qualitative evidence to say there is a problem. And they approached the Local Authority Overview and Scrutiny Committee and presented their findings to them. And they agreed that this needed to be looked at. So Hampshire County Council set up a project board, and they invited representatives from the different therapists to sit on this project board, along with representatives from the Parent Carer Forum and also Commissioning Service. And this small group then spent time unpicking how things were working in Hampshire and what was working, what wasn't working well, and where it wasn't working well. But they also took time to actually look at how things done elsewhere. And they found that there was Wiltshire had a service model that they felt would work better for them in Hampshire. The Commissioner also persuaded the 5 clinical commissioner groups to come together to jointly commission one service for the whole county. This was needed, A, to make sure there was no postcode lottery, but it was also going to be a much more efficient way of actually commissioning this service. The parents and the project board and the Commissioner all worked together to develop the new specification and work with the Commissioner going through the tender process. And so now there is a new multidisciplinary service where the different therapists work together, so it's much easier for them to coordinate their work. There is a telephone triaging service, because what was happening a bit before, some people were getting seeing who maybe didn't need seeing and others weren't. So there's a triage in place to make sure that the people are being referred and being referred appropriately. And as a result, children are now being seen in the set waiting times, and they are having their regular reviews, and families are much happier with the service. So I've managed to explain this process in about 3 minutes, but actually this whole process took Hampshire about 3 years. So I do recognise that change takes time, and if you're going to do it properly, you need to take time to do it. But what happened here was, this aspect was to begin with, if we had this project board, you get the right people sitting on it, because you do need the practitioners as well as the parents on board and the commissioners and managers, and actually working together and picking it and finding out what the solution is. So the last example I'm going to look at is from Leeds, and it was because it addressed the problems I mentioned earlier around behaviour, sleep, toilet training, which are very common, and again we hear very often from families that they actually aren't getting support on these issues. I think what's even sadder for me is I often hear from parents whose children are 13, 14 who are now, their behaviour is so challenging, they're talking about residential settings and discovering these parents were never given any information or guidance on positive behaviour strategies. So this is why I particularly like this example. Again, the Parent Forum picked up there was a problem. Parents wanted support on these issues. In this case, they approached their local community paediatrician who they had a very good relationship with and said, we need some help with this. He replied, well, I don't have the capacity to help within my own centre, but what I will do is let's just set up a working group and see if we can find some solutions. And the paediatrician invited the head of community services to work with him on this in the Parent Carer Forums. And again, they set up on the working group, they invited the community nurses, or somebody from community nursing, somebody from the special school nursing, to sort of sit on this working group to just say, well, this is the problem, can we find some solutions? And through the dialogue, they discovered that the school nurses in the special schools actually had the skill and the knowledge to provide advice and support to families on this, and actually were already doing so informally with some parents who approached them on this issue. So it was agreed that they would put this on a more formal basis. It was agreed the school nurses would allow 1 day a week to providing advice to parents, that parents could ring for appointments. They decided an eligibility criteria about who could access the service, and the Parent Care Forum agreed to let parents know about the service, so families heard about it. And so from this, now families are being helped on these issues, and the bonus of this is the paediatrician is finding his time, he's spending less time in clinic talking to families about these issues, and he's freed up to do more clinical work. But the other nice thing is because they started having a dialogue and well, let's look and for solutions. Since then, the paediatrician is now holding some of these clinics in the special school, because in the dialogue, somebody said, well, wouldn't it be great if we could do this? And we said, well, okay, it's not impossible. And then the advantage of that, of course, is the children are not having to go out of school for appointments. And it also means it's much easier for the school nurse to actually sit in on those clinics if it's going to be helpful. So this example really illustrates this thing about what works is getting the right people around the table, listening to each other, and sort of trying to work together to find solutions. So finally, just to say that, I hope from this you've understood how parent-carer forums can actually help commissioners around all 4 stages of the process in terms of assessing need, getting feedback on how service is experienced, helping to explain to you what changes are needed to the spec to make it work, helping through the procurement process as well, so providers can understand what type of support is needed, and very much helping to monitor the service by providing feedback to make sure it's working well. And about their parent care forms, if you think back to that diagram at the beginning of this webinar, they've got families in the forums who are accessing so many different health services. So if one of those services you're going to come up to recommission, think about approaching a parent care form and saying, can you help us? Can you give us feedback of the service? Would you like to work with us on recommissioning the next contract? So moving on to the secondary forms, just the third part of this webinar. And what I'm going to do now is really talk about the local offer, the new duty for joint commissioning, the role of the designated medical officer, education, health and social care plans, and also parent and young people participation. And this is just going to be a whiz through, but really against the background of what I've said before, why I think that the semi forms are really an opportunity to improve and bring about change and how it might help. For those of you who haven't found it yet, the Statutory Guidance, Special Educational Needs and Disability Code of Practice 0 to 25 years was published in July 2014. You can see the reference code there, so if you Google you should be able to find that. So if you haven't found that and read it yet, do read it. So the local offer. Hopefully most local authorities will have now produced the local offer. It's supposed to be there for the 1st of September. And this is a local offer of services that expects to be available for disabled children and young people up to the age of 25 years. And these are services provided by education, health, social care and the voluntary sector. And in the local offer, local authorities and clinical commissioning groups have to be very clear about the eligibility, who's eligible for this and how to access the service, and who is responsible for providing what, and also what families can do if they're not happy with the service. I would also mention that local authorities and clinical commissioning groups have a duty to involve parent carers and young people in decisions about these services. So I'm assuming most of you will have written your local offer, but it will need to be reviewed. And when reviewing it, do bear in mind not just the importance and the sense of actually involving parent carers and young people in this in reviews. But earlier I sort of talked about the gaps that are happening in services, and I am hopeful that the local offer might actually help prevent some children and families falling through gaps that are currently happening. And though this actually might help, because I do think if parents and children get that information and support early on, it can prevent disabled children needing much more expensive services later on. So for instance, dental care. Many children, if you've got a child with an autism, learning disability, some of the rare syndromes, it can be really difficult for them to visit the dentist. And often these families are not told about community dentists who have been trained and can actually are much better at working with these children and young people. And what happens is because they're not getting that dental care, later on they end up needing to go into hospital and having an anaesthetic and having their teeth removed and dental surgery. So simply signposting families to where they can get support to support their children's dental care could help save money later on. Toilet training I've mentioned before. Helping families to toilet train their disabled children to become continent can reduce costs for both health and education. If you've got a child in school who's not continent, then within the school somebody is having to provide support in actually around the child's continence needs. And again, if they're not continent, the continence service, health is having to provide continence products for that child. So if we can help support them early on, there are savings for you, but more importantly, it's so important for the child and young person of helping them and helping their self-esteem if we can provide support on these issues. I've mentioned sleep before. Sleep-deprived parents are very common, but also siblings, brothers and sisters of disabled children are not sleeping, also have disturbed sleep. So great potential by actually improving health outcomes for the whole family. And behaviour, providing families with positive behaviour strategies early on can minimise those children developing a challenging behaviour later on, and hopefully there would be less need, there always will be some need, but there would be less need for referrals to CAMS for challenging behaviour and referrals to children, to residential settings, because people can no longer manage at home. So joint commissioning, there is a duty now for services to be joint commissioned and across health, education and social care around the SEN reforms. But what I wanted to say is, well, it's just such common sense to do the joint commissioning. Sorry. Yeah. So here's some examples really about how it makes sense to do joint commissioning. This one I picked up from Surrey, where they discovered if health didn't provide a disabled child with an electric wheelchair with risers, what was happening is the education was having to spend even more money on providing support assistance to push the child around the school, but also adapting the classrooms. If social care are not giving disabled children access to short breaks, and social, which is so important for those young people, as well as to give the families a break and a bit of respite. Family stress levels increase, and there's an increased demand therefore for health services. And again, if disabled children are not being supported in school around communication, around behaviour, around social skills, then it's going to lead to more children needing a referral later on to child adolescent mental health services. So it makes sense to work together and to do joint commissioning. It will take time, but what I'm really hopeful is this whole process of just getting people around the table together and actually looking at it in this joined-up way will lead to much improved in the way the Commission services are given. I think there's a key role in the designated medical clinical officer for SEN. All clinical commissioning groups have got to appoint a designated medical officer to coordinate and support the implementation of the SEN reforms. That includes education healthcare plans, but it's not solely educational healthcare plans. It's all support around SEN, and it's a case of working strategically across health, social care and education. Their role is to coordinate the role of health input into education healthcare plan needs assessments, but also very much to build relationships with local commissioners and people with joint arrangements for SEN, and really encourage joint working through pooling budgets and partnership arrangements. I do think it would be really useful for the designated medical officer to actually be very mindful of how clinical pathways can work effectively or not work effectively, and they might want to review their own clinical pathways and check are there bottlenecks in their own area which are delaying children being assessed and getting that appropriate support provided early on. Who funds what can be extremely confusing, I think, to families and probably to professionals too. At the moment, an NHS provides equipment for a child's nursing or medical needs. The local authority children's services should be providing equipment for daily living and social care. And education should provide equipment for aids to support a child's learning. What this often leads to is disagreements about who is meant to be funding what. This causes delays getting support. And this is a very typical situation. Is the child has a communication aid at school, but school is saying they can't take it home and use it at home. So the child is not getting the full benefit of this communication aid. It means at school they can communicate, but at home they can't. And of course, in the school holidays, at the weekends, they're not getting the benefits of using those aids. I'm hoping that pooling budgets will really prevent all of these sorts of issues occurring and save people a lot of time in arguments. So moving on to education healthcare plans, in the previous system we had a thing called School Action and School Action Plus, which is what schools put in place to support the majority of children with SEN, which came out of the school budget. That's now been called SEN support in schools. And before we had statements for children aged 0 to 18, and after that learning disability assessments. And now we've got this new system where we have education healthcare needs assessment and plans for children aged 0 to 25, as long as the children remain in training or education. And what does that going to mean for health? Well, previously there was health input going into the statement process, and often this was in the way of reports being sent over. I think what will happen now with the EHC plans is, first of all, the health assessment is going to be much more focused on the support needs of the child and also the outcomes that people want for the child. So I'm hoping that the information going into the EHC plans will actually give everyone much more clearer information about the type of support the child's need on various issues which are listed here. So the assessment is possibly going to be more thorough than the one that was previously provided by Health to support the statement process. And when we talk about EHC plans, what I'm really hoping is people aren't going to go and have a look at the EHC plan. There's a set format, if you like, for EHC plans with different sections. What I'm really hoping is that people are not going to just see it as a form to fill in, but actually see it as a process. And this is where, when I talked about the team around the child process earlier, I would hope, and I see that the EHC plans certainly have the potential to mimic that process. So if you think about the team around the child, the process was to begin with, was to get input from all the different professionals involved with that child, and very much the child and family, to say, what are the support needs? What are the aspirations of the child and the family? What are the things that need to prioritise? So the EHC plan, if you like, step one is the process of getting to understand what the child and young person's needs and aspirations are. And very much the first section is around finding that out from the child and family. The next three sections is around finding what their support needs around SEN, health and social care. But this is where it needs to be thought carefully. That doesn't mean health is only thinking about section C on that form, because that health assessment is going to influence what goes into section B, which is around the child's special education needs. So for instance, if the health assessment notices there's problems with coordination or hand-eye coordination, fine motor skills, then that is an SEN need, and how can we support the child to learn to develop these skills? And again, if the health assessment sees there's a problem with mental health issues around the child's feeling quite depressed because they haven't got friends, for instance. That has an impact on B, because what can we be doing in school to improve the social life of the child and help them have social activities, but it could also influence B in terms of perhaps short breaks could give this opportunity for the child to develop social opportunities to link with other kids. So this is why this assessment needs to be much more holistic, looking at all the outcomes for the child and the young person, rather than thinking, which box am I meant to fill in? Once that step's finished, the next step is where you sit down and think, okay, so what are we going to prioritise? Because it is important that, you can't always work on everything at once, so possibly we need to concentrate on some things to begin with and come back later to the other things. So step 2, which is section E, is very much where, and the child and the family is very involved in this, when we agree, well, what are the outcomes that we want to be working for in the next year or two, and how are we going to get there, and how are these different people, the family, health, social care educators, all going to work together to help the child meet those outcomes. And it's very much looking at what steps will be taken to help the child meet those outcomes, and what will be achieved, and how will we know if it's working? How often is the physiotherapist going to come in to review the progress, for instance, and maybe set new interventions to help the school and family develop the child's mobility. So finally, step 3 is really the next sections, where it's very, very clear about who is going to provide what to help the child and young person meet those outcomes. And again, anything that is to do with helping the child learn would actually be within the section F, the education provision, and actually funded by the local authority. What is in section G, the health provision, would be funded by health. And I've just given you some examples of what might fit in the different sections. And we'll go back to toilet training again. If you were supporting the child to become toilet trained, then there might be people within the school as well as the family providing that support. But the continence service might well be providing products to support that process to help the child meet that outcomes. So I hope that sort of helped introduce you to this idea of how this is very much joined at working at an individual level as well. Personal budgets, parents, families are going to be offered personal budgets to fund some of the provision. There is an expectation that more over the next few years, more families will be taking up personal budgets. More money will be available for personal budgets. What I found when I was trying to understand EHC plans, the documents that I found helped me most was IPSIA. You Google IPSIA, you'll find they've got a checklist they set out. It's a short document that just sets out legally what must be included as a minimum in education and healthcare plans. But I also found as reading some of the worked examples that have been sent on the same Pathfinder site from Portsmouth and Southampton helped me begin to get a feel of how it works and how it hangs together. There is a transitional period. It becomes law from the 1st of September 2014, but there's a transition period. So children and young people with existing statements, they are still valid, and gradually they will be transferred over by April 2018. It is expected that probably when a child's statement is due to be reviewed, or possibly they're going from, there's a transition maybe from one school to another, that would be a good time to actually replace the existing statement with an EHC plan. But the priority initially is for those new entrants who haven't got a statement, therefore they need to be assessed for the EHC plan. And also those children and young people who might be moving on to further educational training, they would be the priority to begin with. And so gradually over time, over the next 3 years, you're going to be seeing more children and young people require EHC assessments. it is expected that the number of children eventually with EHC plans should be similar to the number of children who have existing statements. But obviously it's going to take 3 years at least for these families to be picked up and to actually be given their EHC plans and go through the assessment process. For those who want to know more about the transition, there is a document out that the DFE have provided around the transition process and what the duties and timescales are. So I've put a link for that on this slide. And finally, I hope you've picked up in hearing these examples how the participation of parents and young people is really important to help services actually understand and provide services that better fit and meet families' needs. Parent care reforms have been established in most local areas, I mentioned that earlier, and have been working on implementing the SAN reforms. So if you're not in touch with them already, please do try and make contact with them and work with them. They could be really helpful for you in identifying what shortfalls are in your local area, but very much working with you and helping you to find solutions to this. The contact details for parent care forms are on the Contact a Family website. You can also find their details on the National Network of Parent Care Forums website. But really what I'm hoping to send reforms, it's about actually everyone working together. So at an individual level, bringing the different people involved with that child together, thinking about how can we best support the child. And at a strategic level, looking at how we can most effective use of resources. And for that to work, it does require to get all the people involved, including the family, into the dialogue. Because it's only by having the dialogue that actually we find the solutions. And it's very much listening and understanding people do have different perspectives depending on where they're coming from, and it's important to listen and understand all of them, because when we find solutions that work for all of them, those are the solutions that work. And of course monitoring and making sure solutions do work. So I'm afraid we have run rather long, but I will pick up the questions that have come in. The ones we don't have time for, we will be putting on our website a list of all the questions and answers that have come in during this session, so you can pick them up there. But one question that's come in, somebody's put a few, what if a child, a few people have actually come up with a question, what if a child has health needs but not special education needs, so they're not eligible for an EHC plan? Well, the answer to that is, if a child has health needs, long-term health needs, they should have an individual healthcare plan. And this can be initiated by a member of school staff or a health professional. And there's more guidance on that from the Department of Education. There's a new guidance that came out recently supporting pupils at school with medical conditions. But I'll make sure there's a link to that when I put the answers to questions up on the web. But I would say that often if a child has a disability, which means it's harder, it hinders them in actually accessing education and accessing the facilities that other children are provided for other children, they might well be considered to have SEN. So I would actually go back and look at the SEN Code of Practice as well and their definitions there. Somebody's asked the question, are there good examples of how a personal health budget has been included in an EHC plan? Looking at the, you can see that actually on the SEN Pathfinder website. They have an information pack on personal budgets, and they have got examples in there. Let's see. Oh yes, Varshadadi said parents from BME communities find it very difficult to navigate the systems, and yes, that is very, very true. They do. It is hard enough for parents to navigate the system when they're sort of English is their first language. But imagine when English isn't your first language, or where you're living in very isolated or rural communities, it's even more difficult. And I would hope that the local authority maybe considers that, how they consider making their local office more accessible to minority groups, and maybe by approaching these groups and working with them to make sure they're aware of it and making sure it is accessible to them. And finally, I've had a lovely comment from Buckinghamshire, and so let's leave on a good, happy note. They say the good news is in Buckinghamshire there's a community nurses team who work with children and young people who have a learning disability. They support parents and children and young people around key areas of need mentioned, such as sleep, behaviour management, continence, puberty, and they're very happy to share more details of their services. So I'll try and post that up on the website again with the answers to all the questions that I haven't got time to take today. So again, thank you very much for joining us. When you sign off from this webinar, you'll have a questionnaire launched. Please take time to complete it because it's going to help us plan what future online training events you want, what topics you'd like to see. And as I said, the webinar and questions and answers from this webinar will be on our website in 1 week's time, and we will email all of you to make sure you know where the link to that is. If you feel this webinar would be useful to other colleagues, please do let them know about it, and I do hope you found it helpful. Thank you.